Welcome, everyone. This is the monthly PNQIN Maternal Equity Bundle webinar. And we're so excited to have the Mount Auburn team presenting on their equity bundle work today. So folks are just starting to be let in from the waiting room. We'll give it another minute or so. In the meantime, this is our agenda for today and our usual housekeeping items. Please type your name and institution into the chat. And an optional share for this month is we'd love to hear if your hospital team has had a QI success, big or small, over the last month. So whether you started a new project or finished a project, implemented one test of change, or is beginning to see, some improved results, we love to hear about it. So please share your QI successes in the chat with us. As usual, please mute yourselves when not speaking. Feel free to type your questions into the chat during the webinar. We'll have plenty of time after our team presentation today for some discussion and Q&A. And as always, this session is being recorded and will be uploaded to our website with the slides afterwards. I'm going to check the chat for any QI successes. Good morning, everyone. All right. And I'll turn it over to Dr. Meadows for to wish you happy Black Maternal Health Week.
Yeah, I was going to say good morning, Massachusetts, but now it's, I guess, afternoon there. So hello, and this is Black Maternal Health Week. I just wanted to honor, acknowledge, and recognize that it's a wonderful thing for so many in our country when we, now have these public health moments where we can recognize the fact that there are things we need to do to make sure that all communities that we serve are receiving the respectful care, the clinical care, and the great experiences that we know that we can give them. And so it's just fantastic to be doing this work, this maternal equity bundle during Black Maternal Health Week. Last year, we did a panel where we showed the aftershock viewing. We had a panel of speakers who presented during our spring summit. I'm having a hard time saying the word spring because it was April, but that was spring, so spring summit. And this year, April 11th through 17th, which is always usually the time frame for Black Maternal Health Week, we're just acknowledging that our work for our maternal equity bundle really does work to improve outcomes for all populations and making sure that we're disaggregating by demographics to make sure that the people that we're serving are all getting great experiences and outcomes with a reproductive justice and birth justice framework. All right, we'll go to the next slide. I also wanted to just welcome our team that's presenting from Mount Auburn. I wanted to say thank you. I've got a chance to get a peek at your slides and also really excited for the audience to hear everything that you're going to present, and want to say thank you for all the work that you're doing. We'll go one more slide, and I just wanted to sort of set the stage a bit. One thing that we noticed from our presentation of the data last year, and as well, and I say last year, meaning in December at our fall summit, was that there's a couple spaces of opportunity. And early on in us building governance for doing this kind of work in our departments, we have asked that people form diverse equity committees with a community partner. We've asked that people think about what their equity goals are, their SMART goals, their AIM statement, even put out an equity statement or an anti-racism statement for your department or within partnership with your hospital. And then also ensuring that we have a PREM in place. Those were our structures that we were looking for to help support teams doing this work. And we've really had a number of teams, I think now with the number of folks that submitted data this time or this month for February, we have 100% of teams that presented data that said, hey, we have an equity team. We're now starting to see an increase in the number of teams that are saying that they have a SMART goal or an AIM statement, and we'd love for folks to communicate those goals and those statements to their faculty and staff. And I really want you guys to listen in towards what Mount Auburn will present, because I think they also have a really great aim and goal, and the way they present it is really nice, and something that many of us can emulate in our different spaces. I actually took a little bit of page from your book and thinking about what we're going to do here in San Diego. So I want to say thank you to the Mount Auburn team. But with that, I'll turn it over back and we'll go to the next slide.
Right. As always, we thank and acknowledge the many members on our PNQIN Maternal Equity Bundle work group for their support over this last year, last several months. They are a big reason why this bundle is the way that it is. And we also thank you, the participating teams, for hanging in there with us and continuing to work so hard to make these important changes in your departments. So I'm going to go through a few slides of announcements, and then I'll turn it over to the Mount Auburn team. So this is our third to last webinar for the Maternal Equity Bundle webinar series. In May, we'll hear from Lowell, and then we're skipping June because June is our spring summit this year on the 26th. So no webinar in June, but then we'll come back in July to hear from our last team, Tufts. So hope you all are able to make it to these webinars. This is just a friendly reminder to keep submitting your equity bundle data. We mentioned this on last month's webinar. We've been seeing a little dip in data submissions since the beginning of this year, but proud to report that we received 10 submissions in March, and folks submitted an additional 4 hospitals submitted for February. So we're back up to seeing some larger numbers. So keep submitting. This is how the PNQIN team's able to determine that we're still on track and doing well. Reminder that this equity bundle in this current version will wrap up at our June summit, and we're already looking ahead to implementing the perinatal mental health conditions bundle with an equity lens this fall. So that said, 3 months left of the equity bundle. Let's finish strong. If you're struggling to submit data, please let us know and we'll do our best to support you. Another note on data, just another plug that reports are available upon request. So if you're submitting AIM bundle data and would like a report for your hospital, just shoot me an email and let me know which bundle you'd like it for. I create them in the order that I receive them. So this is always available. Now for a couple, a job posting. PNQIN is looking for somebody to be our AIM initiative sustainment lead. So we now have several bundles under our belt, and we know for our older bundles, for hemorrhage and hypertension in particular, new best practices are coming out all the time. And so we're looking for somebody to help keep our eyes on those topics and to help us update our resource library and host occasional webinars on emerging topics. So this is a position we're currently looking to fill. So if you're interested, please send your resume and cover letter to me, please. People waiting room. There is a great opportunity from Maspert TTA that runs out of Boston Medical Center. They are hosting an in-depth motivational interviewing course between May 13th and June 14th. The information is here on the slide. I'll also be sending it out in my follow-up email, and Caroline is posting links in the chat while I talk. But this is a really great free opportunity to learn a wonderful skill. And for those of you who were tuned into PNQIN between 2021 and 2022, we did a couple motivational interviewing trainings as part of our COVID vaccine initiative and heard some really favorable things. So please take advantage. On April 25th, the Region 1 for New England for the U.S. Department of Health and Human Services is having a free webinar on advancing birth equity and maternal health in New England, which builds upon their September 2022 summit. So this is free to attend, and we welcome you all to join. Also on April 25th, our friends at the Institute for Perinatal Quality Improvement are having a free webinar on lessons learned from statewide collaborative efforts to improve response and recognition of severe hypertension. So be sure to tune into that as well. March of Dimes is having their March for Babies coming up soon on May 11th. I believe Massachusetts AWHONN has a team that you can join. Otherwise, there are several other teams, or you can join as an individual, happening in downtown Boston on the Esplanade. We recently had a Massachusetts Speak Up Champion training in March, which was very well attended, and all champions have the opportunity to take the ambassador course, which is a continuation of that education. The next ambassador course is coming up on May 17th and is free to attend. And then anyone who would like to take their Speak Up education further can apply to be faculty. The application is due June 1st. If you plan to become an ambassador, we encourage you to start your application early, even before the ambassador course, so that you're not running low on time when the faculty deadline comes up. And of course, our PNQIN Spring Summit is on June 26th from 8:30 to 4:30 in Norwood. The theme of this summit is Partners in Purpose. Collaboration is key to family health and equity. So we have a really great lineup that you can see more details about on the registration site. We have some great keynote speakers, as well as presentations from hospitals participating in our grant-funded work. So we hope to see you all there in June. And lastly, PQI has recently come out with their new Birth Equity Modules course, which are 4 around 30-minute web-based modules that were designed for perinatal professionals working to ensure health equity in their organizations. So PNQIN had a hand in helping design these modules. And if you work in Massachusetts in the perinatal space, you have free access to these modules between April 1st and September 30th, so for 6 months. The code to get that free access is here on the slide, and Caroline and I will also be sharing Caroline in the chat with the link, and me via email. You'll be hearing about it for the next 6 months, so hopefully you'll pick up on that code and take advantage. And these modules were actually based on a series of webinars that PNQIN and PQI did in early 2022. The webinars, these topics line up perfectly with the modules, so you're kind of able to receive this information in either a webinar or module or both. So we hope everyone enjoys this new content. And lastly, of course, the PNQIN website is a treasure trove of awesome resources for quality improvement and maternal and infant health. So we encourage you to check out our resource library. And I'm done. So thank you all for, there's lots going on, lots of great things to take advantage of. But now I will turn it over to our Mount Auburn team for their presentation. Thank you, everybody.
Hello, everyone. Good afternoon for those in Massachusetts. My name is Caroline Regelous. I'm one of the midwives here at Mount Auburn Hospital and our lead provider of our equity team. Today on our call, I have myself and Leslie MacDonald, one of our key physician participants or members, as well as Natalya Carney, our one of our nurses participants. And so we'll all be sort of presenting different parts of our equity presentation. So we can go to the next slide. So, we just sort of outlined a little bit about our hospital here. We're a teaching hospital associated with in the BILH network and Harvard Medical School. We have upwards of 2,500 deliveries a year. We partner with a community health center called Charles River that serves a lot of our under-resourced, definitely not all, but a lot of our under-resourced patients. We have a really wonderful diversity of types of people on our committee, which has been really exciting to see develop. So a good group of our midwives, our lead social worker, our two nursing leadership RNs, Teresa and Megan of our postpartum and our labor and delivery floor have been key in our committee, as well as Brittany, who is our educator. Natalya has been influential. She's been really our PNQIN ambassador to our facility, so she's been wonderful. And Dr. Nicole Grady is our neonatologist who's involved, and then Leslie MacDonald is involved as well, who is working not currently in practice with us, but still really key in a lot of work at our facility. And so she's really key in our committee. It's been pretty exciting as well to learn about our larger DEI committee and to partner with them. So Val Harris, as well as different committee members, I've been able to just merge our work with their work and to see the overlap that is obvious, but wasn't necessarily recognized before. So that was really really an interesting development through, after developing our committee. We've had very strong department and leadership buy-in and support. Dr. Ed Wong, and then now our new chair is Dr. Brett Young, have been very supportive. Julie Mann is our department head and one of our midwives, and then there's also Julia Dickinson, which is the head of our midwifery team. So all very supportive of our work. You can go to the next slide. So our patient population, you'll see here, is, over 50% identifying as Caucasian or white. The next highest group is identifying as Asian, followed by other. So we, are not sure, but we're, I'm sorry, not Asian. So Hispanic next at 14.7, then Asian, identifying as Asian, followed by those identifying as Black or African American. So that's sort of an overview of the patients, the population that we serve. You can go to the next slide. This is just a timeline, a little visual and timeline of our journey so far. So back in fall of 2024, we had a group that attended the summit and really sort of started this conversation. So that was really exciting. And in January, we kind of initially met together and we said, should we do this? Should we actually sign on? And so then in March, we did officially have the buy-in from our leadership team and signed on to the equity bundle and started submitting data. That was approved then in April 2023. And then our committee finally solidified in May of 2023 and started to meet monthly since that time. We started to identify our SMART goals in the summer of 2023 and kind of see where we wanted to start our work and sort of identify our aim statements at that time. Our first project that was that we identified and we attempted. Not all attempts are successful, but it was a really great learning experience. So we applied for the ACOG grant, equity grant, and we partnered with our community health our community health center and a grant writer with them to apply for that grant, which was really educational for myself and all those involved, and a really good experience. So that was in July 2023. And then in November, we first presented our data that was divided by race and ethnicity, which Leslie will talk more about later on. But that was our, we have been historically presenting data every month, but we had never divided it by race and ethnicity. So that was the first time we did that. Since that time, it's kind of been a continuum of different projects. So between fall and spring, we've disseminated our poster for our patients. So these are available. Our commitment to equity, equitable care. These are in our 4 top languages in all of our ambulatory settings. And then we sort of compiled the different languages in a poster form, which are still just being printed, but they're going to be up in our labor and delivery sort of admission area, as well as the postpartum floors for good visualization as patients are now able to, walk around in labor and postpartum more. So really, they really look wonderful. So, and then since that time, we've worked on our translation, access to translation services, having better availability of iPad and translation services 24/7. We were having some breaks in availability in some night shifts and some weekends. So we were able to widen the availability as working with our interpretation services department as a whole. And then we're still in this process is our survey, right? So the initiation of our PREM survey and the ongoing collection of that data. So that's a little overview timeline. And you can go to the next slide. Again, this is a long statement. This is our equity statement. So this is our anti-racism statement that's on the first page of our website. The website's currently being overhauled and is set to be rolled out, we are told, this month. So we're hoping that this will be actually available to be seen. The plan is at the when they first come to the prenatal care portion of our website. This is the first thing that will be seen with our new website. So that's our anti-racism statement, and we've shared this with our departments as a whole. But I actually, with your discussion this morning, Callie, I was reminded that we need to also send a refresher to everyone with a new launch of the website to remind them about this statement. You can go ahead to the next slide. So this is our sharing our commitment. These are the posters that are available. It's translated into our top languages. We were able to partner with our ambulatory safety committee in disseminating the posters. Our DEI committee, we were able to get some funding from them to actually have the interpretation services provided. We've since come into some more funding for other interpretation of documents, which has been really exciting, but that wasn't available when we were trying to get these translated. So we were able to apply for a grant and receive that for this project. And our educator, Brittany Dunn, she made this poster, which is a really good visual representation of our commitment as well. You can go to the next slide. This is our first aim statement. So our goal was to by November of last year, we wanted to initiate the PREM survey. We did not make our deadline for sure, but we definitely had started the initiation of it by that time. We wanted to initiate the PREM survey to receive about 30% of our postpartum patients to respond to the survey, and then use the data to really guide our work going forward. So we have developed the survey, we've had it translated. It's available on our postpartum units and on our ambulatory settings for patients to fill out before discharge or at their 6-week visit. And now we're in the collection phase, and Leslie's going to talk a little bit more about the exciting pieces and the difficult pieces of this portion. So we're in the collecting and reporting of the data phase of this aim statement. So you can go to the next slide. And this is just a look at our PREMS survey. So, we aren't part of the team birth model, but we have utilized PNQIN's survey and have then had it translated into our top languages. We've developed a QR code for access, so people can have access either virtually to fill it out or on paper. And there's sort of envelopes that they can put them in for confidentiality. And can remain anonymous if they prefer as well. And we kind of, identify that we really need to know where we're starting from, and from the patient's perspective, to know where we can best, channel our efforts. So we're really excited to see sort of where this data will take us. You can go to the next slide. And one thing I think and I'm going to turn it over to Natalya here in 1 second, but one thing I meant to mention, I forgot, was that when we were developing our group, our committee, we had a really great diversity of, types of providers and interdisciplinary. But what we haven't had, and what we're really trying to work towards, is a community member. So we've reached out to a few different people, but it hasn't sort of come to be yet. But that's really a goal we have, to have a patient representative on our committee to help guide our work as well. So that's a goal we have in the future. So I'll turn this over to Natalya, one of our nurses, to talk a little bit about our second aim statement.
Perfect. Can everyone hear me? Am I okay? All right, so I'm Natalya Carney. I'm a staff nurse on the labor floor here at Mount Auburn Hospital. And thank you everyone for having us. This has been an exciting journey for us. So I'm going to dive right into it. So our second aim statement was geared more towards education. And as you can see here, we are just getting started on this goal. So our plan was by this past January to implement a plan for increasing the number of staff that I don't know what this message is. So to increase the number of staff that have that undergo bias and respectful care training, with a goal of 50% of the nursing staff and 50% of the OB providers to be trained by January of 2025. So our plan to prepare for this was to survey the staff to see who has had formal training, and to create a list of options for integrating training into existing forums such as SIM, Grand Rounds, and HealthStream, and then create a subgroup to develop a formal curriculum for the training. And then to implement our plan is to implement the training over a specified time frame, and then to develop a feedback and evaluation forum to assess the training itself. And then to our goal is to have to increase the number of providers, staff, and nurses to complete the training, and then explore a mechanism to analyze the data from the surveys and the evaluation and the feedback, and then to measure the percentage of staff that completed of our total staff that completed the training. And then we hope to repeat the PREM surveys responses before and after the training, and to use the PREM survey results to evolve the training to meet identified needs in the survey. And then ultimately, we hope for 100% of the staff to complete this training, and for it to be ongoing. So again, we're just getting started with this goal, and so a lot more to come. Next slide, please. So just to talk a little bit more about the education and that's we have in place. So currently, our simulation are 4-hour sessions that is required for all staff that work on labor and delivery, and supported by CRICO. And in looking back on sessions that we've had over the last several years, it looks like we have incorporated equity and bias training. Examples of this are compassionate communication. In 2019, we included respect for patients' right of refusal for medically indicated care into our medical scenarios. And in 2020, we introduced implicit bias awareness to our simulation. In 21, we incorporated accepting cultural customs in the setting of fetal demise. And in 22, we included bias related to refusal of care for religious reasons into our simulations. And in 23, we included trauma-informed care. This year, members of our Racial Justice and Equity Committee were invited to the planning of the simulation committee to consult on how to include an equity lens into the scenarios that involved discrimination, racism, gender bias, and how to use respectful communication to include respectful communication to discuss these scenarios along with the medical scenarios. So myself, having gone through the Speak Up training and the way our simulation scenarios are conducted, there's usually 6 nurses, maybe 2 OB providers, 2 midwives, a surgical technician, and a unit coordinator. And when we divide into groups, they're even smaller. So after the scenario is played out, the debriefing and discussions are in small, intimate settings, and which is similar to the breakout groups in the Speak Up training, which the scripted scenarios that were done to discuss some of the scenarios that in the Speak Up training I thought would be a great idea to incorporate into the medical scenarios to include, that would be a great way to incorporate an equity lens into the scenario. So anyway, that was my suggestion for simulation. And in Grand Rounds is another existing forum for education. In 23, there has been topics that included equity, including uncovering the dark history of America's maternal mortality crisis, along with The Time Is Now, Improving Perinatal Mental Health, and this past January, pregnancy associated violent death. And moving forward, the goal is the inclusion of an annual lecture specifically related to equity. In our monthly M&M meetings, they are encouraged to include discussions focused on equity and potential bias in review of the monthly cases as well. And the department is exploring use of their monthly meeting time for formal training, such as Speak Up or Upstander training as regular education time. And also our department was just received a generous philanthropic gift, which was specifically intended to be used for equity and gender bias training. So we're still deciding what to do with that gift and how to best use it. So anyway, so that is the existing education and how our department plans to incorporate equity and bias training. Okay, next slide, please. Okay, so I'll just talk a little bit about the ACOG grant that our group applied for. So the goals of this grant were to decrease severe maternal mortality and to combat a culture of racism and inequity, to increase data-driven practice change, and to advance public education in a post-Dobbs era. So like Caroline mentioned, Mount Auburn partners with the Charles River Community Health Center, where 71% of the population identifies as Hispanic or Latino, and 73% of these patients are best served in a language other than English, and 80% of these families live below the poverty level. And it's a really, really unique population overall, and really would be worthy of this grant and the goals of this grant. So what we've proposed is a funding for a part-time community health worker at Charles River with goals of enhancing perinatal services for the Latina patients. So we hope that this position would support a centering pregnancy care model for prenatal care, to facilitate social supports and connection to resources for these patients, to lead a postpartum support group, and to increase staff capacity for perinatal mental health conditions. So our group partnered with the Mount Auburn OBGYN department and the Perinatal Mental Health Committee to prepare this grant, which was a integration of systems to benefit a community partner, and a wonderful collaboration of inpatient, outpatient groups for these patients. Unfortunately, our application was declined, but many lessons learned, and especially Caroline, blood, sweat, and tears, was the champion of this grant. But anyway, that's it for me. I'm going to pass it on to Dr. MacDonald. And again, thank you for having us.
Yeah. Thanks, Natalia. And just, to share the last few slides with you guys, these are not necessarily meant to, we don't really have any specific data to present, but I think we wanted to draw attention to some of the things that are happening in our department, really outside of our committee itself, but still with the lens of equity. A lot of the education we have asked to sort of help drive that, but there's a lot of the education that Natalia was talking about that has gone on in the past and is planned for the future that is really nice to see that others in our department are taking this work seriously, even when they're not necessarily sitting on our committee. And one of the other things that we have been doing is really taking a shot at disaggregating our OB data. So in the fall, we took our normal statistics and tried to disaggregate it by race, by those who identify as Hispanic. We also looked at some language data. I think like many people I've talked to who are trying to do this work, we struggle a little bit because there is not a perfect single system to get this data out of. And, I've had the unfortunate experience of running our data from our electronic medical record system using the exact same dates and getting slightly different results. So, I think trusting it is a little bit of a challenge right now. And especially when we look back over a 5-year time period, which is what we've tried to do, the race, ethnicity, and language data is incomplete. And, we've also struggled a little bit to identify which differences are statistically significant, although one of the midwives has a partner who works in this space and has graciously volunteered to meet with us and help us try to figure out some of the just basic statistics. And then, we did use a grand rounds time to present the data we did have to our department, but I think, as is also very common, many providers and staff sort of express some skepticism related to the data. And, we were upfront about the challenges of getting accurate data, but also I think there's always a little bit of resistance when you are presented with a difference, say, based on race, and people don't feel that that could really be possible. So we're continuing to try to refine our data, get it more consistent and where we feel like it's most accurate. And then our plan, excuse me, is to present it and see where we are. You can go to the next slide. Next slide. So the other group within our department that has taken on looking at their data through an equity lens is our QA committee. Excuse me. And again, not so much to highlight on any one particular data piece, but just to show that we are looking at things like our readmissions. And this was just a very small sample You know, we look at all readmissions within 30 days. And, you know, it does seem to show that when you disaggregate that data, that our Black and Hispanic populations have higher readmissions rates than they represent in our population. So it's something for us to continue to gather data on and try to assess what the significance of that is. We also, if you just look at all of our QA charts, which are really those patients who have higher morbidity because they're having events that have gotten their chart to QA for review, again, our Black and Hispanic populations are sort of overrepresented when you compare them with their percentage of our entire population. So that's something that we are keeping an eye on. And then again, we're looking at things like postpartum hemorrhage, incidence of choreo, a bunch of different quality indicators, and trying to disaggregate that data by race too. And we've really just started doing that. We probably now have about a year's worth of data. So it's time for us to put it all together again and take another look at it. Next slide. And then I think Caroline mentioned this a little bit earlier. Some of the work that also came out of QA was when we have charts that show up in QA for review, one of the things that we've asked reviewers to do is also not only look at them from the medical care standpoint, but also did we document the use of interpreter services for all the sort of key points of care, like their admission, if there's a discussion of a major care plan or induction or the need for surgery, obviously with consent for surgery and discharge planning. And again, these are very small numbers over a short period of time, but what we found is about 2/3 of the time we were documenting it inconsistently or not at all. And, you know, I think most of us feel like we probably are using interpreter services more frequently than that, but trying to get people consistently to document it so we can show that. So we've done a few things to try to make it easier. We've created some smart phrases within Epic that the providers can easily just plop into their note and will document the key pieces of information. We also partnered with our Mount Auburn Hospital DEI committee for funding of, you know, our translation of our poster and our PREM surveys, like Caroline mentioned. We've also had a lot of conversations with our leadership, and I think the really nice thing is our department chair is really committed to placing a priority on helping us find funding for translation of a lot of our patient information. And then we have worked with our interpreter services to get more iPads that have a broader range of language so that we will have interpreter services more available 24/7 to help improve access. And, you know, we'll continue to look at this data and see if we can at least demonstrate that now we're able to document the use more consistently. Next slide. And I think, you know, just this is our last slide, and we certainly would welcome questions, suggestions, anything that you can think of. I mean, I think our challenges are those that many people face when trying to do this work. Caroline mentioned our continual efforts to recruit more diverse members of our committee, and in particular, a community representative or a patient representative. Obviously, we have some work to do. You know, I think the struggle for data collection and getting it accurate and then being able to analyze it to where it can be useful to help guide our work is an ongoing challenge. Obviously, identifying funding sources for all of this work is difficult in a time where, you know, healthcare in general is challenged, I think, in financial ways. And then, you know, maintaining, I think a lot of times our committee, we have a lot of great ideas, and it's really tempting just sort of move forward in a more buckshot manner, but also trying to maintain some focus on goals and outcomes that we can measure so that we can really have a sense of if we're achieving what we want to achieve, and then continuing in an ongoing way to engage our broader provider and staff community so that this work gets integrated and prioritized into sort of all the work that we do. And I think that that is our last slide, but really happy to have any questions or suggestions, thoughts.
That was a terrific presentation. I just want to say thank you. Wow, that was, you know, it's interesting that we talked a lot in the beginning of doing this work. Oh, sorry, my video's not on. We talked a lot at the beginning of doing this work about how it's really hard to overcome the sort of inertia that comes along with doing this work, because it's sort of hard. You know, Mimi, I'm looking at your face because I'm thinking, I remember conversations we had and talking about, well, what exactly does it look like to do equity work? And it's just so wonderful to listen to this whole presentation on how your team has really been very clear cut about what it is, the specific actions you took to set a goal, think about your change concepts and what work you've moved forward, and then those challenges, which I think are true for anything, whether you're doing equity work or any other clinical work, integrating it into your QA. I think that was wonderfully done. And then how do you further integrate it so that all the work you're doing becomes sustained and continues to move forward? I just think that it's just such a great presentation, and I want to say thank you. It just feels good to know that, you know, your hospital system, your L&D is doing all this work to make sure that everyone feels seen, heard, valued, respected in childbirth. I think that's just great. I'm just looking in the chat now to see if we have other questions for folks. But if folks do have questions, feel free to unmute now to ask your question as well. And while we're waiting for that, I actually do have a question, Dr. MacDonald, around the QA work, and this is for my own edification here. So when you integrate into your QA to look to disaggregate data and to look at the data, does your QA meet monthly, and do you do that with things monthly, or do you do it on the sort of project base? Like, so if you're talking that month about breastfeeding, you'll just do it with breastfeeding project. If you're talking a particular month about hemorrhage, you'll do it with that, but you don't do it every time.
No, we track the data monthly. So, you know, we meet each month and there's a list of cases that are to be reviewed, and they're assigned to different reviewers. And then generally, you know, I sit on that committee with really the purpose of, I go through and for each of the charts, gather the race, ethnicity, language data. The reviewers look at whether or not, you know, interpreter services was used. We've also started to try to incorporate into our conversations whether or not we think bias potentially could have played a role in, you know, the care provided. I think that mostly comes up around language, especially if we've shown that we didn't document interpreter services use. You know, then if it wasn't used, could that have injected a bias into the care? And then at roughly once a year, although occasionally if somebody has a question about transfusions or choreo or whatever, it seems like we're having a rash of this, then we'll look at that data. But at least once a year, then we look at, our data in a broader sense. What's our postpartum hemorrhage rate? Who's getting transfused? Who's having severe hemorrhages? And choreo, and then we are disaggregating that data. So it's a little bit of both. We gather it on a monthly basis, present it at a minimum of once a year, but then, occasionally things come up in between.
Okay, thank you. I heard you say some of that, but I was feverishly taking notes, and so I was missing a
All
couple
right.
of words, so thank you.
Yeah, sure.
Bonnie Glass?
Just, I have this question, is that in a number of initiatives that we've done with PNQIN over the years, we've incorporated, I mean, we've factored in the contribution of home visits, and I wondered if that's something you've looked at all. Because patients, who have a lot of risk factors, we would, in a number of the places where I've worked, we would try to be sure that they got a home visit, or that they were going to return to the obstetrician or midwife's office before the traditional 2-week period.
I can speak to this. And I remember listening to some of what you were, I forget which presentation it was, Bonnie, but I really appreciate the how home visits can be vital. I think the struggle we have is we don't have staff. We don't have we don't have a group that visits from our facility, and so I think what we do is, well, one thing is I start education about lactation services in pregnancy. So I encourage people to find a lactation consultant before they deliver and make an appointment for 5 days after they go home. So like on a simple recovery infant feeding, that can be a really good thing. And then, we do before the 2 weeks. So, if someone is at high risk, then we ask our nursing staff at whatever office they're seen at to call them, within 2 days, 3 days, or for them to come in for a blood pressure check or something like that. So it isn't, I wouldn't say it's as formalized as it probably could be. But there's like an email communication for high risk discharges for follow up. It would be really wonderful if it was actually a home visit, really consistently. That would be fantastic. I know I had that for my first child and not for the other two, and it was just fantastic. So, yeah, I would love it to be more formalized, but that's sort of how we approach it at this time.
Well, thank you. You're making a really good effort.
Yeah. I also think that some providers are still leveraging video visits, in that sort of short interval, like if there's somebody that they're worried about, either from a mental health perspective or something where you don't necessarily need them to come in, but it would be really nice to touch base with them. I still think that occasionally, not so much as we were doing, say, during COVID and maybe immediately post-COVID, but I think we still leverage sometimes those video visits in this time period, which is kind of another way to touch base, but like Carolyn said, very informal and sort of individually provider dependent.
Thanks, Mimi.
Yeah, hi. Great presentation. I loved a lot of your graphics and the way that you showed the data and all the timeline, particularly. I thought that was really cute. My question has to do with, I feel like all of us on these calls are so engaged in this and always seek to understand what we can do better. But I know that when you're on the front line, you have a tendency to just focus on like getting through the day, getting through the shift. Mm-hmm. How do you engage? Do you have any tips on how or what did you do to engage the front line to help them to like have the same goals and to be engaged with all of this and to like sign on to your goals and your aim statement and all that? Any good tips for all of us?
I think our nursing leadership is really vital in their we have sort of we have board rounds every 12 hours. So, but for sure in the morning, there's a time where all interdisciplinary comes together, and there's like an educational piece. So our nursing managers on both postpartum and labor plug what's happening. So when we were, launching the PREM survey, that's when they would plug that. Or when we were launching our new iPads for interpreter services to kind of catch everyone at one spot on the floor. Like board rounds. On the floor, sort of not just a patient sort of review, but also a little educational piece, and using that time.
That's good. Thanks.
I
It's
also think,
challenging.
yeah, it really is. I also think that one of the nice things is that we do have a little bit of overlap. So some of the people who sit on our Racial Justice and Equity Committee also sit on our Perinatal Mental Health Committee. And so, that helps these equity ideas seep into that group. I attend QA, and that is a different group of people, but that allows me to bring sort of the equity lens to that group. And so I think it's a big enough department that there's a lot of different ways. Like Natalya was talking about, our simulation team is a different group of providers that is trained to develop and put on our simulation. And so Natalya going to that group also allows sort of these ideas to get out there. I think we also struggle. In fact, at our last meeting, we had a conversation about how do we get this stuff back in front of the rank and file frontline staff, both, nursing and hospital staff, as well as our provider staff and our ambulatory staff. We have an ambulatory patient safety committee, which Caroline and some others have brought bits and pieces of this work to. So I think we're trying not so much to hit everybody over the head with the club, but trying to let it leak out gradually and continually. But it is a challenge, I think.
Well, I want to say, just given the time with 3 minutes left, just want to take a moment again to give you guys all a Zoom reaction round of applause and say thank you to you for all the work that you're doing. It's really inspiring. It really is. It's just impressive to see how it's been integrated into all the things that you're doing and the conversations you're having about it. And so I just want to say on behalf of the PNQIN team, thank you. And really hopeful that, as many of the participants on this call got out of this talk what I did, because I can see a couple things we're going to integrate here that I think you've kind of shed some light on how you were able to be successful there. So thank you.
Thanks so much.
Thank you, guys.
Thank you all.
All right, we'll have our next team presentation next month, as Kaylee presented in May, and then we'll see everybody at the summit in June, and we'll follow up with our last team presentation in July. So nice to see you all.
Yeah.
Yes.
Thanks.
Thank you all for tuning in. We'll see you next time.